The next is, yes, endoleyk. CTA, endoleyk. Gloria Adam, I ask the lady, come to the podium.
Hello everyone, my name is Gloria Adam. I'm a radiologist in Aджибадем City Clinic. And related to the previous topic, I'm not sure that in the software of the MRI we have functional MRI. About your recommendation, I'm not sure we have it.
We're able to acquire the sequence and do it the post-processing later.
Maybe, but I don't think that they have ever done it there. I'm not in that center where Dr. Polomsky is. Okay. Yes. Yes, Philips. Okay. My topic is City angiography for endoleyk evaluation post-EVAR. You know, City angio is important both previous and after the procedure for aortic aneurysms. The rate of complications actually is 15 to 30%. EVAR is really with lower morbidity and mortality compared to surgical repair, but there is the risk of complications and the need for follow-up. The most common device-related complication is endoleyks, 15 to 30% again, and device migration. Endoleyks, what is endoleyk? The return of systemic arterial blood flow into the excluded aneurysm sac, which can lead to enlargement of the sac, more pressure over the wall, and the risk for rupture. There are early leaks and late leaks, early within 30 days and late after 30 days. Most complications happen within the first 3 to 5 years, but there are also cases after the 5th year. That's why there is importance for CT to follow up at 1 month, 6 months, 12 months, and even annual surveillance after EVAR. There are 5 types of endoleyks. The second is the most common one, the first and the third, but are more dangerous. Type 1 endoleyk is when there is insufficient attachment of the stent graft lead to the native arterial wall. It can be proximal or distal. Usually you see it at these parts of the stent graft. It is usually detected at the time of placement of the graft and is the most common cause of abdominal aortic rupture, so usually it requires treatment. I will show you several cases from the practice, how they treated the aneurysm and after that the endoleyks. This is the first case of patient with abdominal aortic aneurysm. Before there was put MFM stent graft in the thoracico-abdominal area due to dissection. And you see also aneurysm of the iliac arteries. Then what was done, an endurance stent graft with iliac extensions was put in the abdominal aorta and also Valiant thoracic stent graft due to the dissection. But what else can we see? We can see an endoleyk, which is type 1B in the distal part, endoleyk. So it was follow-up, that's what was decided, and the endoleyk actually enlarges with time. That's why it was decided to be treated. Here is the endoleyk with 3D visualization on CT, and this is the effect after the treatment. No endoleyk in that area because endurance stent graft was put in the common iliac artery to seal further the area that is leaking. Type 2 endoleyk happens when there is retrograde flow from aortic branches which are connected to the aneurysm sac. Usually it is the arteria mesenterica inferior or the lumbar arteries, and we see the leak usually in the periphery of the aneurysm sac. This is the most common endoleyk. The majority happens within 6 months of stent graft placement. And up to 40% can resolve. So usually in this type of endoleak, we can use the wait and see approach and to intervene if there is persistent leak more than 6 months or there is growth of the aneurysm sac. The first case is a patient with abdominal aneurysm of the aorta and also the iliac arteries, and an endurance stent graft with iliac extensions was put, also big graft of the right interior iliac artery and coiling of the left interior iliac artery. But on the follow-up, so we can see that there is endoleak type 2 from lumbar artery. So the decision was to coil the lumbar artery with concerto coils, and you see that there is no more leak in that area. The second case is a patient with aneurysm of the abdominal aorta and the common iliac arteries. Because it is too close to the renal arteries, it was decided to do the chimney technique with Bentley big graft stents to the right and left renal arteries and endurance stent graft with iliac extensions. But what we can see after the follow-up of the patient after the procedure, there are 2 endoleaks, type 2, from lumbar artery at the back of the aneurysm sac and from the arteria mesenterica inferior at the front of the sac of the aneurysm. So the decision was to be treated with coils, both of the arteries. And the patient was followed up further. Here we can see that there is no endoleak from the front of the aneurysm sac and coiling of the left lumbar artery. So this leak is not coming from these 2 arteries, but is coming actually from the iliac artery, which is type 1 endoleak. You can see here the endoleak, and after placement of endurance stent in the right common iliac artery and coiling of the internal iliac arteries, that there is no more endoleak. Type 3 endoleak is rare. It results usually from defects in the stent graft or disconnection between the modular components. So it is divided in type A and type B. It requires intervention because it's connected directly to the blood flow of the aorta. This case is of a patient with shaggy thoracoabdominal aorta, but also aneurysm of the abdominal aorta infrarenally. So it was decided that it will be a 2-step procedure, surgical of the abdominal aorta with a tube graft. And after that was placed Valiant Captiva stent graft and sinus XL graft, and also the left renal artery was dislocated the ostium lower because there was stenosis at the ostium of the left renal artery. And at follow-up, we can see that initially there was good connection between the 2 stent grafts in the thoracic aorta, but with time there is enlargement outside the stent grafts and 1 endoleak which happens between the 2 stent grafts, which is probably type 1 endoleak proximal. But why I'm showing you this case? Because with this follow-up, we can see also that at the level of the truncus celiacus, there is enlargement a little bit with time of the abdominal aorta with peripheral thrombosis. And what happens with the sinus XL graft? Destruction in the lower 1/3, probably due to the pressure of the new form aneurysm of the abdominal aorta. And actually, this patient, today, he must have had a procedure of stent graft with fenestrations for the vessels that are coming out of the aorta, and we will see what the result will be next week. This is a second case of abdominal aortic aneurysm infrarenally with peripheral thrombosis. The decision for treatment was with stent endurance with iliac extensions and follow-up CT. Also, there was placed like prevention for endoleyk coil in the arteria mesenterica inferior. And at follow-up, we see there is a small leak, type 2, from the lumbar artery at the back of the aneurysm sac, which on follow-up, what happened? Which on follow-up was slightly enlarged, not so much, and it was decided to be coiled, that lumbar artery. But what else? On follow-up, we can see that there is new endoleyk, and what actually has happened is a destruction of the stent graft. You can see there is separation between the modular components, which is type 3 endoleyk. There was the decision for treatment was to put endurance stent to connect this area that is missing the stent, and there is no endoleyk after that. These are type 4 and 5 endoleyks, much less common. I don't have examples for them. Usually they don't require treatment. Type 4 is due to graft porosity, rare with newer devices, and type 5 is due to endotension, when we see enlargement of the sac but no true leak in the sac. And for conclusion, I would say that CTA is an inseparable part of the diagnosis of aortic aneurysms and post-procedural diagnosis. Findings are essential for treatment success, whether it will be endovascular or surgical. The cases I presented to you were endovascularly treated. EVAR complications happen in 15 to 30% of patients. Of them related with the devices is endoleyks, 15 to 30%. The most dangerous one is type 1 endoleyk and also 3, but it is much rarer than type 1. The stents that were used for correction of abdominal aneurysm or sealing of the leak site was endurance stents, which are nitinol stents and polyester graft, and post-endoleyk procedures which were done were coiling and additional stents to seal the leak part. Thank you very much, and you can follow Radiology Talks on Facebook or Instagram, and if you have questions, I'm open.
Wonderful talk. Yes, you see everybody is enthusiastic after your talk. Perhaps I will, because that is a session, tips and tricks. I will give a tip because I'm a lazy guy. Sometimes I was not able to find the feeding artery branch in a type 2. And what did I do then? I placed the patient in the CT unit, punctured directly, and injected glue. I don't know if you have ever done that, but in some cases it's helpful when you have no other way to find the feeding artery. Mm-hmm. A tip. Yes, it must be at least, otherwise you cannot puncture it. Yes, but under CT guidance, it worked well. Mm-hmm. So, there is another question or comment.
Congratulations. In fact, what Gloria is showing is how important is the surveillance. So probably in several minutes, as a live case, Dr. Stankov will show you one of such a deconnection of the modules of the stent grafts. And it is, in fact, in patient, a medical doctor, who didn't make surveillance imaging for 5 years. And nowadays he has, and Dr. Janevska will show, it's probably a good idea to show the case, yeah, in order you to be aware about. And in fact, during the surveillance, that is have to be at least once per year. It's we are taking care about late complications, late endoleyks, because in case it's described and recognized early, it's relatively easy to be treated. In case it's recognized in the late phase, in which it's possible even not to be recognized. So the patient can have a rupture of the aneurysm before being treated. And yes, in fact, it's important to have at least per month in case there are kidney problem of the patient, at least CT without contrast or Doppler ultrasound, duplex. And in case on the CT, ordinary without contrast, there is some problem. In this case, we are proceeding with the contrast CT, like we had a patient yesterday. But the surveillance after the endovascular treatment is crucial.